Good morning from Athens. I want to thank you and thank Brosmed Company and all the panel for the kind invitation to show some data from our cath lab. It's the largest in Athens and in our country. More than 1,500 PCIs per year, about 100 CTO cases last year. So this is about low-profile balloons and how we can cross the uncrossable lesions. Let's go to our first case. It was about a male patient, 60-year-old, with previous coronary artery disease, hypertensive, dyslipidemic, and ex-smoker. His current condition was angina at effort, and has preserved the LV function with ejection fraction of 45%. And a positive stress test in inferior and posterior lateral wall. And this is his angiogram in the RCA. He has a complete occluded distal RCA with not too good collateral from LAD. We see an outstanding LAD. And we decided to recanalize this chronic totally occluded RCA. According to hybrid CTO crossing algorithm that we usually use to plan our procedures, and according to not having appropriate intervention collaterals, we decided first choice to be undergrade procedure, undergrade wire escalation, and as well with no long lesion length, we decided to try undergrade wire escalation first. So with the Mamba microcatheter flex, and first we used the Gaia second wire, try to go distally. And the second choice was Gladius CX. There was no such good viewing of the distal part of the artery. But Gladius proved successfully distally. But after that, we had the same problem as described in the previous cases. We could not pass a small balloon to dilate and go on. So the lesion proved uncrossable despite our different positions on the wire. And at this point, we have to give a solution. In that case, we have to do something to improve support or to do lesion modification. And as my friend, the previous speaker, showed, there's an algorithm we can try to follow. First, we have to increase support to have a more supportive guide like ambulance. We have to use a guide extension like Agila. We have to do anchoring balloon. Then we can use more profile balloon inflation for predilation. We could do balloon acid microdissection with same balloon and called the granuloplasty. We can switch to smaller profile microcatheter. We can switch to stiffer microcatheter. We can use laser atherectomy, external car crash. We can use also Carlino technique or deliver a rota wire and perform rotational atherectomy. In this case, is both we have to sacrifice wire position and recross. Or we can go retrogradely. We first choice have to use a small profile, low profile balloon for predilation. And here comes this balloon. It's Alveo HP balloon dilation catheter with 0.75 millimeter diameter. This is the smallest and high pressure CTO balloon catheter. We can go up to 20 and 24 atmospheres. It's ideal for CTO lesion and for complex as well calcified lesions as described. And we have, this is the sizes from 0.75 to 2 millimeters and all the lengths from 5 millimeters to 30 millimeters. And it's because of its way that was manufactured, it's really smooth. So that's why you used it here, and it was successfully dilated. After that, we used bigger balloons. And we had this result. We decided then to put a stent, but after planting a stent there, we lost a PL branch. Patient had chest discomfort, and we had to recanalize the occluded branch. We tried several wires, filter XT, and but finally, Conquest Pro 12 Confianza could pass through the struts with an Alveo HP 1 millimeter balloon supporting and passing the struts. And after ballooning, we managed to have a final result. Patient was fine, no chest pain. And this way was to pass through struts with this fine balloon. Second male patient, 56 years old, with a previous pacemaker 5 years ago, hypertensive and diabetic. He had angina. And there was this branch. It seemed like intermediate, but we were not sure about his this proximal cap, because we were not sure if it was intermediate, if it was diagonal or obtuse, highly obtuse marginal. So we had to recanalize, and we decided to use an epicardial collateral from LAD to go retrogradely with Corsair Pro XS and Whisper MS wire. We went through epicardial collaterals. You can see the wire moving. And this is a pass to the totally occluded artery retrogradely. Went finally all the way till proximal cap. After that, we tried to do antegrade T-pin with antegrade microcatheter into the guide. We had no success. And then we used the just marker technique, using the retrograde wire as a marker and point the proximal cap of the occlusion, and another grade wire. In this case, we used Gaia third, went in a parallel way till distal, in the parallel way with retrograde wire. You can see where the wire is till distal in the occluded artery. This lesion proved uncrossable as well, and we had to use, again, Alveo HP 0.75 to dilate. And after that, we could use bigger balloons, and we had good dilatation. And finally, we did use the reverse tap technique in the proximal circ and the OM. It's a technique that we have demonstrated, and we had a final result. Patient is fine with no angina after that. So the key learning points is that the uncrossable lesions, CTO and no CTO, sometimes is not an uncommon problem. It comes about 10% in CTO cases that we do every year. And before we had these weapons in our hands, we had really problems treating these cases. So all the weapons that we can use should be on the battlefield. A low-profile balloon may be the option to tackle these demanding cases. And even the borders of the uncrossable lesion, dilating such balloons, we can do plaque modification and solve our problem. We can cross also through stent struts and occluded branches, and we may need this kind of balloons as well. And always P balloon with a fine profile and a high rate burst is the lower profile in the market is undoubtedly a very useful tool. Thank you very much, and I can hear your questions as well.